So to continue on with radiation therapy, the exposure is the amount of radiation delivered to the tissue, and radiation dose is the amount of radiation absorbed by the tissue. So with that being said, three factors are used to determine the absorbed dose, and that's going to be the intensity, the duration, and closeness or distance of the radiation source. So the dose of radiation is always less than the exposure because some energy is lost on the way to the tissue. Radiation therapy is usually given as a series of divided doses because of the varying responses of all cancer cells within the tumor. So we talked about radiation being like 5 days a week and going 6 to 7 weeks. We can use radiation as standalone therapy or in combination with surgery, combination with chemo, combination with surgery and chemo. A couple of different types are going to be the teletherapy and brachytherapy. And teletherapy is a radiation source outside of the patient. And remember with this that because the source is external, the patient is not radioactive and is not hazardous to others. And the brachytherapy means short or close therapy. And with that, the radiation source comes into direct, continuous contact with the tumor for a specific period of time. So with brachytherapy, this opportunity provides a high dose of radiation in the tumor and is very limited dose in the surrounding normal tissues. So brachytherapy is inside or close to, whereas teletherapy is outside. With all types of brachytherapy, the radiation source is within the patient, and the patient will emit radiation for a period of time and is a potential hazard to others. So we need to remember that to educate the patient on safe practices, and their excretia must be handled according to guidelines established by the institution. Some of the side effects of radiation therapy, they can be acute or long-term, but the effects are limited to the tissues exposed to the radiation. So that is one good thing about radiation. Regardless of the radiation site, patients do undergo some common systemic effects. So taste changes, and taste changes are thought to be caused by metabolites released from dead cells. And so many patients develop an aversion to red meats. And fatigue is another common side effect of radiation therapy, and fatigue may be related to the increased energy demands that the body is using to repair those damaged cells. And radiation-induced fatigue can be very debilitating and really can last, for a short period of time or last up to months. Some degree of bone marrow suppression is going to occur regardless of the treatment site. So we just need to be careful with our patients that do have bone marrow suppression. So we want to, watch for increased risks of infection, watch for anemia, and then watch for those decreased clotting factors. Because any form of radiation can damage and mutate normal cells and normal cells' DNA, radiation therapy does cause an increased risk of secondary malignancies. But again, each person reacts differently, so we want to just provide some straightforward basic education to all of our patients. Some of the things that your book talks about with patient-centered collaborative care are listed out on this slide. So, be thinking about how we can protect our patients, help to decrease anxiety, protect the area that is protect the areas that are not being radiated to help decrease disruption of normal cells and normal tissues, and then protecting their skin as well. We need to think about their nutritional support. Along with that nutritional support, be conscious of them having exerostoma or a dry mouth, which can affect the quality of life and increase the patient's risk for tooth decay later in life. So we want to make sure that our patients are visiting the dentist. If we have bones that are irradiated, that can put those bones at risk for fractures later because it causes decrease of bone density. So discuss with our patients side effects of radiation, and then also talk to them about exercise and sleep so that they are getting some exercise, but also taking that time to rest and recover between treatments. Chemotherapy is a cytotoxic systemic agent that is used for cancers that have spread beyond that local area. So we've now moved beyond the primary site and we have secondary tumors. Chemotherapy is used to help cure as well as increase survival times for our patients. When we think about chemotherapy, it can be used in combination. It most likely won't be used alone, but it can be. But we do see chemotherapy, radiation, surgery. We kind of see all of them utilized together as well. So it's a very systemic approach. And chemotherapy does have some selectivity for killing cancer cells over normal cells. However, tumors with rapid growth are often more sensitive to chemotherapy. So when we think about those cells that undergo rapid mitosis, you need to think about skin, the hair, the intestinal tract, blood-forming cells. But when we're thinking chemotherapy, it does have cytotoxic effects on healthy cells as well. And so that puts our patients kind of at a higher degree of risks. There's several chemotherapy drugs listed out up here. When we think about the alkylating agents, that makes DNA strands bind tightly. And if we have DNA strands binding very tightly together, hopefully what will happen is that it inhibits cellular division, because when we talked about the normal cell, remember, once that DNA replicates, it kind of has to move to each end of the new cell. And so the alkylating agents don't allow that to happen. The anti-metabolites, those anti-metabolites resemble normal metabolites that kind of fool the cancer into using this artificial metabolite. And when it attaches onto that, it prevents cellular division. The antimitotic agents interfere with formation and action of microtubules. So microtubules forming, when microtubules form in normal cellular division, it's kind of like the tubes that help prepare for the cell to kind of move apart. And so the microtubules occur really in the prophase and the metaphase. And the microtubules help that cell to split. And so the antimitotic agents interrupt that process of the microtubules so that that complete cellular division cannot take place. And so we don't have rapid replication of tumor cells. The anti-tumor antibodies, those are good for helping damage the synthesis of DNA. So it's disrupting the S part of the cell cycle where DNA is replicated. And if we don't have DNA replication, then we don't have cellular division. The topoisomerase inhibitors disrupt the enzyme topoisomerase, and topoisomerase is needed for the synthesis of DNA, because again, with the life cycle of the cell, we have to have synthesis and replication of DNA in order for cellular division to occur. So that's one, so there's a lot, really, when you think about chemotherapy drugs, really they all work much the same way in preventing cellular mitosis. Typically we use more than one drug to help increase the effectiveness of therapy. And so when we have that increase in effectiveness, we have more cell death, which then kind of means more side effects to our patients. Some of the treatment issues, we need to think about dosing. And in class, I talked about dosing. And really, when we think about dosing, it's dosed off of milligrams per square meter of total body surface area. So when we think about that, that takes into consideration the patient's height as well as weight. Excuse me. Chemotherapy drugs are given on a regular basis and are timed to maximize cancer cell kill and then minimize damage to normal cells. So we want to give the patients the maximum amount of time for these cells to die, but also the minimal amount of time for so cells can recuperate and try to help diminish the amount of normal or healthy cell kill that we have. So when we think about scheduling, scheduling is on a regular basis, and we want to schedule time to allow normal cells the time to recover from injury, but we don't want to give too much time that we allow time for cancer cells to recover. So typically what we see is about a treatment every 3 to 4 weeks. And then we use that for a specific period of time. And a lot of those things are going to be dependent on like your doubling time and mitotic index. We need to provide patient and family education because that's going to be critical in helping patients maintain optimal schedules for best outcomes. Also going to help when we educate our families, kind of help with some of those side effects and preventing complications. When we think about administration, there's many ways to administer chemotherapy: IV, intrathecal, intravesicular, intraventricular, so lots of different ways. We can also administer oral cancer meds. And remember, it doesn't matter which way they're being delivered. Any way is just as toxic to the person taking the drug and the person handling the drug. So really, whatever route it is, our patient and our handler are at greater risk. So some complications with administration, extravasation, which is a picture of this hand. And with extravasation, it occurs when the chemotherapy drug leaks into the surrounding tissues. So it's like infiltration, but it's much worse than infiltration because we are giving a vesicant. And remember, vesicants are chemicals that damage tissue on direct contact. And so when we see this occurring, we can, some of the things that you might see, obviously pain. Tissue loss is going to be huge, and then a huge risk for infection. And so now not only do we have our chemotherapy patient that is immunocompromised from the chemotherapy, now we've caused this direct insult to their skin and made a huge area for a risk for infection. So there are going to be specific protocols for handling chemotherapy drugs, handling the excretion from the patients receiving IV chemotherapy. So I talked about that it does require special training and competency. It also requires close monitoring, being very vigilant when we are administering these type of medications to our patients. So some of the side effects we need to think about with chemotherapy, and two of them are listed out on your screen. So infection risk and anemia, thrombocytopenia risk. And so with infection risk, they're both related to bone marrow suppression or myelosuppression. And so with infection risks, we have neutropenia, and neutropenia is low white counts. And if I have a low white count, I have a risk for infection. Remember, with neutropenia, there's no infection risk to others, but others cause that infection risk to the patient with neutropenia. So we discuss some of those neutropenic precautions, the isolation, so that we aren't taking our bugs into these patients. Really, the side effects on the hematopoietic system are most common from chemotherapy and really can be the most life-threatening. And really, when we think about neutropenia, myelosuppression, thrombocytopenia, anemia, those types of things, those are going to be reasons that physicians change the dosage of the chemotherapy or change the timing in between, because we don't want to set our patients up for really serious complications. such as the anemia, neutropenia. When we think about alopecia and mucositis, there's really not a lot that we can do. Those things really just happen. And so what we want to do is try to prevent complications from those side effects happening. When we think about treating these side effects, we will talk about biologic response modifiers. So we talked about Neupogen and Neulasta. We talk about Epogen and Procrit, Numega, Provenja, Sargarmostem. So when we think about that, there's several different medications that we can use when we're caring for our patients with myelosuppression. So besides medications, we can also do transfusions. And we talked about different types of transfusions: packed blood cells, packed red blood cells, platelet transfusions, plasma, and granulocyte transfusions. And really we talked about what are our responsibilities as the nurse. And truly our responsibilities as a nurse, they're listed out up here. So we want to make sure that we have verifying the prescription with another RN, making sure that we have ABO and RH compatibility, checking expiration dates, checking the blood bags, checking blood bank numbers, looking at the recognition slips, and then always remember to double check. We want to make sure that before that transfusion, that we get a set of vital signs immediately before starting the transfusion. We want to make sure that we have a consent signed, and then begin that transfusion slowly and stay with that patient for the first 15 to 30 minutes. And while we're staying with our patients during that time, it's a great time to do charting. It's a great time to talk to your patients and find out, just kind of get more personal with them, get into their level, find out what's been going on, how their day is. It's a really great time for communication. Also during this time, we want to ask our patient to report any unusual sensations. And so we talked about some of those side effects or some things that could happen with the transfusion reactions, such as fever, chills, shortness of breath, itching, hives, any of those types of things. And then just make sure that we are administering blood products per protocol. So we want to make sure that we get that blood hung within 30 minutes of receiving it, and then not let it hang more than 4 hours, and then assessing for hyperkalemia. And so it's an okay time to put your patient on that telemetry unit and watch what their cardiac rhythms are doing, because again, potassium is going to have the biggest effect on the cardiac muscles when we're thinking about life-threatening conditions to our patients. So acute transfusion reactions, they're listed out up, some of those side effects are also listed out on this slide. So we want to make sure that we are watching our patients quite closely. Some other side effects besides the myelosuppression we need to think about are chemotherapy-induced nausea and vomiting, mucositis and alopecia, which again, there's really not a lot we can do as far as medications to prevent them. With the mucositis, those are going to be sores in the mucous membranes, and so remember, it's anywhere along the GI lining really. And then the stomatitis are going to be sores that are in the mouth. Alopecia is the loss of hair. And truly, hair starts to regrow about 1 month after chemo is stopped. But it's a good thing to educate your patients that this new hair is probably going to be different. And when they lose their hair, we should probably spend some time talking about scalp care, preventing injury to the scalp. And the one thing I think about with that is, our patients in the summertime, and their scalps are exposed to the sun. So wearing a hat or getting sunscreen on, those types of things are going to be important. With chemotherapy-induced nausea and vomiting, really it's kind of an anticipatory, or it can be acute or delayed nausea and vomiting. A lot of time it's triggered before chemo just by thoughts and smells and sounds and just different things. So it's almost like kind of like an anticipated response to receiving chemotherapy. If it's acute, it's going to occur within 24 hours after chemo, and delayed, it's going to be after 24 hours. Really, many cancer drugs are hematogenic, which means they induce vomiting. So the treatment is to administer antiemetics. So it's our priority to coordinate with the patient and their healthcare provider to ensure adequate control of this nausea and vomiting. We want to make sure that antiemetics are started before chemo, repeated, and continued. Tell our patients to get them started right away and then continue using them. When we think of the mucositis, treatment is really going to be a swish and spit with local anesthesia. So we talked about utilizing viscous lidocaine. We might also see some type of anti-inflammatory put in there. We could also see Carafate to kind of help protect those. But if the pain is too severe, we're going to have to think about systemic pain medications. So think about morphine type derivatives. Encourage your patients to rinse their mouths every couple of hours throughout the day because dry mouth can be a problem. So we don't want those mucous membranes getting terribly dry. So we want to keep on top of that. With cognitive changes and chemotherapy-induced peripheral neuropathies, really the cognitive changes can be related to the quote-unquote chemo brain or chemo fog. And chemotherapy drugs typically don't cross the blood-brain barrier, but they do induce inflammation and some biochemical changes. So it's important just to take those thoughts and concerns and consideration to hand, to heart, and really support your patient. Try to help prevent injuries. So keeping them safe will also be important, especially, if you're thinking of the peripheral neuropathies, supporting your patient. Sometimes they can find it difficulty learning new material, and let them know it's okay, and it's going to hopefully get better over time. But it can take many months. The biological response modifiers, when we think about them, they work with the patient's cytokines. So they work with interferon, the interleukins, tumor necrosis factors, and colony stimulating factors to help increase or help boost our patient's immune response. So when you go back to inflammation and you think about the interleukins, those help regulate inflammation and immunity. Interleukins help differentiate the immune system cells, recognition and destruction of non-self cells. The interleukins help charge up the immune system to enhance their action. And interferons are utilized to help slow tumor cell division. So interferons stimulate growth and maturation of natural killer cells. They also try to help inhibit expression of oncogenes. And biologic response modifiers are used for supportive therapy during cancer treatment because of that colony stimulating factors, which induce more rapid recovery of bone marrow. And if I have more rapid recovery of bone marrow, I have more capability of producing cells. So some of those things that we talked about, Neupogen and Neulasta, those are going to help with the neutrophil counts. Epotin alpha or Epogen and Procrit, those are good for erythrocytes. Darbemopotin alpha or Aranesp, those are also good for the erythrocytes. Numega is good to help stimulate and produce platelets. And if you look in your book, there is a table on that talks about some of those common biologic response modifiers. We do have to consider patient side effects because, yes, they can help improve immune function, but some of the side effects of patients receiving the interleukins, oftentimes they have generalized and maybe sometimes severe inflammatory reactions. And so when we think about inflammatory reactions, we think about fevers, chills, rigors, flu-like symptoms, so general malaise. It can also cause some confusion and fatigue and also agitation. So we do need to provide education on those. The monoclonal antibodies, when we think about an antibody, remember, an antibody works to attach to an antigen to essentially kill that drug. So the monoclonal antibody therapy combines actions from immunotherapy and target therapy to help treat specific cancers. So they bind to target antigens, which just means that those monoclonal antibodies help make tumor cells more sensitive to chemotherapy. They help increase the effectiveness of the immune system attacks on the cancer cells. And so they really work together to prevent proteins from functioning and preventing cellular division. With hormonal manipulations, remember, hormones exert their effects only on their specific target tissues. So some hormones make hormone-sensitive tumors grow more rapidly. So if we decrease the amount of a hormone, or by decreasing the amount of hormone, we can help slow cancer growth. So when we think about that, think about steroids. Sometimes we can use hormone inhibitors. We also have to provide some education on the side effects of hormone therapy. So the masculizing effects in women, feminizing effects in men. Then we moved on to oncologic emergencies or oncology emergencies. And so when we're thinking about some of these oncology emergencies, we move through them quite quickly, but do take some time to read about them in your book. When we think about sepsis, sepsis is obviously a condition in which an organism enters the bloodstream. And when we think about sepsis, our cancer patients are really at high risk due to the leukopenia or the decreased white blood cells. And a lot of times with tumor necrosis, because we're giving chemotherapy drugs, it causes tumor necrosis. And that tumor necrosis is what can also cause septicemia. And with septicemia, it can lead into DIC, or the disseminated intravascular coagulopathy. And DIC with cancer patients is usually due to a gram-negative sepsis. DIC causes a problem with blood clotting. So really with DIC, there's a systemic activation of blood coagulation, which causes generation and deposits of fibrin that cause microvascular thrombi and organ failure. So essentially we have used up our clotting factors, and now we're starting to make microthrombi, or very small blood clots. When we think about clinical manifestations, elevated temp, elevated pulse, hypotension, oliguria, change in mental status. So when we think about sepsis and DIC, we want to think about primary prevention, so protecting our patients. Antibiotics, utilizing blood cultures. We also need to utilize heparin to decrease clotting and prevent rapid consumption of circulating clotting factors. We may need to give these patients packed red blood cells or also administer clotting factors. So it's really kind of walking them a fine line. With SIADH, syndrome of inappropriate antidiuretic hormone, we see this a lot of times with small cell lung cancers and brain tumors. Morphine sulfate can also cause SIADH. And with SIADH, water is reabsorbed excessively by the kidneys. And if we have water reabsorption by the kidneys, it's put back into circulation, which essentially causes a severe hemodilution. So hyponatremia is going to be a big problem with the syndrome of inappropriate antidiuretic hormone secretion. So oversecretion of antidiuretic hormone can occur either by the tumor or by the posterior pituitary. If I'm holding on to all my water, my manifestations: decreased urinary output, headache, muscle cramps, weakness. Go back to fluid and electrolytes. Think about what are your symptoms of hyponatremia. Could also cause some heart failure, so think about your lung assessment. Treatment: fluid restriction. We want these people to be on I&O, daily weights. Utilization of democloslin. Democloslin. DEMECLOCYCLINE. And that inhibits the effects of antidiuretic hormone on renal tubules. Getting labs, getting serial sodiums so we know what their sodium level is doing. We discussed spinal cord compression, and that's a result when a tumor or collapsed vertebrae puts pressure on a nerve root. Spinal cord compression can lead to permanent loss of sensory and motor function. So really the hallmark sign is new onset of back pain that increases with activity, when lying down, or when coughing. Pain is typically opposite the side of the compression. So numbness and tingling are also going to be some problems that we're going to see. For treatment, we can use large dose steroids, so dexamethasone, to help shrink down the size or decrease the swelling. We can use radiation to help decrease that tumor size. And if it's related to collapsing vertebrae, we can maybe use braces or surgery, but typically it's going to be a very palliative type treatment. Hypercalcemia is really the most common oncology emergency. When we think about hypercalcemia, obviously it's just, often occurs with bone metastasis or bone cancer, and we can also see it with squamous cell lung cancers. It's having too much calcium in your blood. And with too much calcium in my blood, what are my signs and symptoms? What are my clinical manifestations? Think back to fluid and electrolytes. Loss of DTRs, nausea, vomiting, constipation, bone pain, altered level of consciousness. The severity of the clinical manifestation is going to be really dependent on how quickly the hypercalcemia has occurred. Treatment: IV fluids to correct dehydration. Because again, it's putting so much calcium into the bloodstreams that the kidneys can't excrete it fast enough. So give them some more fluid, kind of try to flush those things out. We can utilize loop diuretics to try to help promote diuresis. So kind of help push things through the kidneys to get them moving. IV biphosphonates to help inhibit bone resorption. Maybe we need to have stool softeners if we have severe constipation. Superior vena cava syndrome. That's when our superior vena cava is compressed or obstructed by a tumor or growth. So when we think about manifestations, think about your heart. Think about what empties into your superior vena cava. It's really the upper part of your body, and then it goes into the right atrium. We're going to have decreased cardiac output. Going to have head, neck, facial swelling, engorged blood vessels. It's a picture of this lady on your screen. We see this oftentimes with lymphoma or lung or breast cancer, because when you think about your vena cava, think about where your lungs, think about where your breasts are. Treatment is really quite palliative. We might use some high dose radiation or maybe use a stent in the vena cava. That's only going to provide us temporary relief. It's not going to be something long term. And the last thing up here is the tumor lysis syndrome. And with tumor lysis syndrome, it's a large number of tumor cells being rapidly destroyed by the chemotherapy and or radiation. Those intracellular contents are released into the blood, and the body can't get rid of them fast enough. So think back to fluid and electrolytes. What are your most prominent intracellular components? So your potassium, phosphorus. We see it a lot of times with leukemia and small cell lung cancer. So the treatment is hydration to dilute the high potassium levels, the high uric acid levels. We want to tell our patients to drink about 3,000 milliliters of fluids several days before and after their chemo. Tell them to utilize those antiemetics. We don't want them to be dehydrated. When we think about having an elevated potassium level, we think about K-exalate. So we could administer K-exalate. We can also use some of those osmotic diuretics, so an infusion with glucose and insulin. We want to try to prevent long-term kidney damage from those components being built up into the blood. Interventions for palliation. So when we talk about palliation, we talk about end-of-life care. We talk about quality versus quantity. It's kind of those end-stage things. So oxygen to help decrease shortness of breath, to help relieve some of that anxiety of being short of breath. We could think about using inhaled morphine. Other drug therapy, systemic morphine, PO. So we want to think about using long-acting morphine, short-acting morphine. Radiation therapy to just maybe help reduce the size of tumors. Thoracentesis and pleurodesis to help get rid of some of that fluid in the lungs, in their abdomen. Trying to get hospice care in to help the family if at all possible. So really it's trying to keep them comfortable. The next thing we're going to move on to is colorectal cancer. And when we think about colorectal, colorectal refers to the colon and rectum, which together make up the large intestine. So colorectal cancer is cancer of the colon or rectum, and truly is a major health problem worldwide. It's one of the leading causes of malignancies in the United States, but it has a very high rate of curability. Typically, most colorectal cancers are adenocarcinomas, which are tumors that arise from the glandular epithelial tissues of the colon. And remember, they have to undergo those different stages in order for it to become malignant. So we have the loss of the suppressor genes and the activation of the oncogenes, increased proliferation of the mucosa of the colon. Maybe we get polyps that form, and then those polyps turn into malignant tumors. Colorectal cancer can obviously metastasize just by direct extension. So it can just go through the colon, or it can spread through the blood or the lymph system. When we think about complications or problems related to colorectal cancer, we need to think about the bowels. So bowel obstruction or fistula formation. The tumor might invade neighboring blood vessels and might cause bleeding in the stools. And so when you think about colorectal cancer, think caution, C-A-U-T-I-O-N. So change in bowel or bladder. A lesion that does not heal. U, unusual bleeding or discharge. T, thickening or lump in the breast or elsewhere. I, indigestion or difficulty swallowing. The O is really for skin cancer, so obvious changes in wart or mole. And N, related to the throat or lungs, nagging cough or persistent hoarseness. Typically, the etiology is the age greater than 50 years old. A lot of times there's a genetic predisposition. We can have a personal or family history of cancer, or family tendencies of the adenomas or polyps in the colon. It is the third most common cause of cancer death in the United States. People that are at risk can take some actions to decrease their chances of getting colorectal cancer and help hopefully increase their risks or their chances of survival. So if people have family members that have colorectal cancer, they should be genetically tested. And if gene mutations are present, that person is at risk, and so we can think about what we can do to, get those screenings done earlier. We want to teach people, regardless of their risk, to modify their diets. So we want them to decrease the fat and refined carbohydrates, and encourage baked or broiled foods, and really foods that are high in fiber. We want to keep things moving through the intestines, because those things, when you think about high fiber, and think, also put in some vegetables, because those things are going to help protect the intestinal mucosa. So when we think about colorectal cancer and you think about your patient-centered collaborative care, think about your assessment. So when we are thinking about the assessment, ask whether vomiting has occurred or any change in bowel elimination. So either constipation, maybe the change of the stool, maybe is there blood, or have they even noticed that? Maybe have they had any like abdominal fullness, abdominal pain, unintentional weight loss? Any fatigue, difficulties doing ADLs, because that could have some maybe relationship to anemias. Really, the clinical manifestations are going to be dependent on where that colorectal cancer is. But really, the most common sign are going to be rectal bleeding, anemia, and change in stool consistency or shape. So your patients might complain of gas pains and cramping, and that's because they don't have complete evacuation of the colon. They might have hematochezia, which is the passage of red blood in the rectum. So really there's lots of different complaints that your patient might have. When we're thinking about laboratory tests, really looking at the hemoglobin and hematocrit, because if our patient has had rectal or colorectal bleeding, that can drop their hemoglobin and hematocrit. We can look for occult blood in the stools. And when we're doing that, we need 2 or 3 separate stool samples. But the downside of that is a negative fecal occult doesn't necessarily mean that colorectal cancer isn't present. Another thing we can look for is carcinoembryonic antigen, or CEA. And that is an oncofetal antigen that's usually elevated in people with colorectal cancer. And the normal is typically less than 5 ng, N as in no, per milliliter. When we look at other diagnostics, we need to think about like contrast barium enemas, CT or MRIs, colonoscopy, sigmoidoscopy. But truly the colonoscopy is the definitive test for the diagnosis of colorectal cancer, because with the colonoscopy we can actually take a sample of the mucosa or the polyps and send it to pathology for testing. When we think about analysis, what are our nursing diagnosis? Potential for colorectal cancer metastasis or grieving related to the cancer diagnosis. So for our planning, what's our plan? We want to prevent or control metastasis. So when we think about that, think back to what we have already talked about. We have talked about surgical management, we have talked about radiation, and we have talked about chemotherapy. The one thing it's with our surgical management is make sure you read through the pre-operative, intraoperative, and post-operative information. And that is going to be a lot of your stuff from basic concepts or nursing too. But most common, the surgeries are going to be colon resection. So that's where we're going to remove the tumor and part maybe some of the lymph nodes and some of the colon. We can do reanastomosis, and that's putting the 2 ends back together from where we have taken away the intestines. Colectomy is colon removal. And with colectomy, we can maybe have a colostomy, and the colostomy may be temporary or permanent. And we may have an ileostomy. And so if we have a colostomy, that is the surgical creation of an opening of the colon onto the surface of the abdomen. And we will watch a little bit of a YouTube clip and talk about colostomy care. Colostomy after surgery, the patient usually has a clear ostomy pouch in place. And so what we're looking at that stoma is the color and integrity of the stoma. And we want to be looking at that each and every time we do our post-op vitals. We want to make sure we're looking at that every shift. A healthy stoma should be reddish pink, moist, and protrude about 3/4 of an inch from the abdominal wall. Some you may see larger, but we want at least that much. There may be a small amount of bleeding at the stoma or initially. We want to refer these people to ostomy nurses. So that we can talk about how to care for the skin around the stoma, how to prevent damage to that surrounding skin, when to change their pouches, those types of things. We definitely need to assist with the grieving process as far as the patient and family goes. So we need to think about the patient's and family's current methods of coping, what their support systems are, and what their present perceptions of the health problem may be, and then signs of anticipatory grief. So think about denial, crying, anger, withdrawal. When we think about staging, it is listed out on your slide, and we did talk about staging earlier when we talked about care of the patients with cancer. Also, with community-based home care, we need to assess patients for their ability for self-management, what their limitations are, what kind of assistive devices they might need. Do they need a nurse? Do they need assistive personnel? Before discharging a patient, we want to teach them to avoid lifting heavy objects or straining on defecations to prevent any tension on the anastomosis site. So if we have a patient that has the re-anastomosis where they put those anastomosis or the bowel ends back together, we want to make sure that we're sending them home on stool softeners. We need to talk to them about the normals of colostomies, so talking about normal colostomy care, the normal appearance, signs and symptoms of complications, how to use appropriate appliances, how to protect the skin, nutritional changes, because we want to talk to them about controlling gas and odor. And then address any psychosocial concerns. So fear of not being accepted, feelings of grief, maybe concerns about sexuality. Next, we move on to lung cancer. And when we think about lung cancer is the leading cause of cancer deaths worldwide. And we talked briefly in class, we talked about lung cancer. The reason it is a high rate of death is because typically patients don't come early with a diagnosis, so they don't have an early diagnosis of lung cancer. When we think about lung cancer, really tumors are present in invading lymph glands, in vessels. Tumors might be in the bronchial tubes. We might have compression of the alveoli. Lung cancer can spread to the lung lymph nodes, distant lymph nodes, and other tissues. So when we think about that, oftentimes bone and liver metastasis. With lung cancer, staging is performed to assess the size and extent of the disease. So we talked about that TNM, the tumor, node, and metastasis. Lung cancer usually occurs because of repeated exposure to inhaled substances that can cause chronic irritation to those tissues. And so when we talked about some of the risk factors, we did talk about chronic irritation. So it could be smoking or it could be exposure from work. As far as health promotion and maintenance, primary prevention for lung cancer is really related to tobacco smoking and stop smoking. The next thing up is the assessment. So consider the history. Ask your patient about risk factors. So not only smoking, but hazards in the workplace. Ask about some of the manifestations, so hoarseness, cough, sputum production, hemoptysis, shortness of breath. Are they able to carry out those ADLs, or do we have change in endurance? Assess for pain and discomfort. Do they have any fullness, tightness, or pressure in the chest that might mean obstruction, or any piercing pain? With your physical assessment and clinical manifestations, really the specific manifestations depend on tumor location. Lung cancer is often really non-specific, and again, the long-term survival is really quite small. because patients typically don't come in right away. With your psychosocial assessment, there's such a poor prognosis for lung cancer. So really, if someone has a diagnosis of lung cancer, it can cause a lot of fear. They might feel guilty or shameful because they have smoked. When we think about diagnostics, typically lung lesions are first identified on chest x-rays because we start least invasive to most. So a chest x-ray, a CT scan, thoracoscopy, actually looking at that lung tissue. MRIs will be important. We could look at PFTs, so go back and read in oxygenation about pulmonary function tests if you don't remember those. Arterial blood gases. So when we think about management and we think about non-surgical management, again, this is all repetitive information. So if you don't remember about the non-surgical management and complications, go back and take another listen to that. Go back and read those in your book. Surgical management, so again, this is doing surgery. So we're actually going to do a lobectomy, which is a removal of a lobe, or removal of the entire lung, which is a pneumonectomy. We can also do segmentectomy or wedge resections, and that's just removal of a portion of the lung. With postoperative care, these patients are going to come back with chest tubes. And so there's a couple of different pictures up here of chest tubes. And when you think about a chest tube, the tip of the tube is used to drain air. And then there's another tube that is placed to drain liquid, kind of at the base of the lung. And then the chest tube is connected together by about 6 feet of tubing. So it's kind of a Y connector. Typically what we see is a 3-chamber unit, which is the picture that you see up on your screen. So you have a chamber that is used for the drainage collection, another chamber that is the water seal to prevent air from moving back up the tubing system and into the patient, and then the third chamber is when suction is applied. And so you want to go back and look at your facility's policy and procedures when caring for the patient with a chest tube. Really, the manipulation of the chest tube should be kept to a minimum, so definitely do not strip the chest tube because that can create more pressure and damage to the lung tissue. We want to assess respiratory status and document the amount and type of drainage in that collection chamber. Pain management after lung surgery is typically a great concern because patients usually have intense pain. So definitely giving prescribed drugs, teaching them about PCAs, so watching vital signs. Respiratory management, once the patient is breathing on their own, really the priority is to maintain a patent airway, ensure adequate ventilation, and prevent complications. So assessing that patient's airway every couple of hours, every 2 hours. Check pulse ox, listen to lung sounds. Assess mucous membranes for cyanosis. As far as additional therapy or palliation interventions, thoracentesis is when fluid is removed by suction after a needle has been placed into that intrapleural space. And so what they use is a suction container that will pull off that extra fluid. And so that in removing that fluid, it's going to allow patient to have the ability to take deep breaths. It might temporarily relieve some hypoxia, but again, this is all palliative, and that fluid will return. And so when that fluid is developed, then the patient will come back in with shortness of breath. So we want to consider that. With dyspnea, dyspnea management, keep them in a semi-Fowler to high Fowler's position. We might need to utilize oxygen therapy. We want to control their pain. And then again, thinking about hospice care will be a big consideration. I'm going to stop here, and on my next slide, slide presentation, we will continue on with neoplastic disorders and leukemia.